So welcome everyone. Thank you for coming and joining us for our first nursing focused webinar with the Medical Cannabis Clinicians Society. My name is Sophie. I'm one of the expert committee members for the Medical Cannabis Clinicians Society, representing nurses' voices as part of our involvement in cannabis medicine. Tonight, I'm hoping we're going to start one of the first of what will be many nursing focused webinars as part of Medical Cannabis Clinicians Society. And I wanted to start with an episode where we showcase some of the major leaps forward in cannabis medicine that have been generated by nurses. And our guests this evening are some prime examples of exactly that. We have done monumental things from a nursing perspective in cannabis medicine. Graham Woodward and Eleanor Owen Jones. I'm going to ask Graham and Eleanor to introduce yourselves, because your career, your CV and your titles and your achievements are so long. I'm going to let you surmise them and then we'll dig into them a little bit more. So Graham, if you would like to just tell everyone a little bit about yourself and what your current job title is for the minute.
Okay, thank you. Thanks for inviting me as well, by the way. My name is Graham Woodward, as Sophie said. I'm a psychiatric nurse by background. I trained with Camden and Islington, was where I learned my profession as a psychiatric nurse. I specialised in drug addiction for 14 years, which was heroin and opiates and crack cocaine was my speciality. And I left the NHS after 14 years and was medical director for a charity. I then joined another charity called Ad Action. I was with the first charity I was with was called Lifeline, but they were absorbed or consumed by Change, Grow, Live. I then left there, went on to pharmaceutical world for 7 years, and then I came out of the pharmaceutical world and joined Althea and set up my access clinic, and then moved on to Lever Clinic, and I'm now the Chief Operating Officer with Releaf. I was the first nurse to be given a license to set up a medical cannabis clinic, although I was the second person, which obviously is galling, and we won't talk about who the first person or the first company was. I tried to circumnavigate them by applying for a license outside of London, because at that point London had a 12-month waiting list, where I applied for a cannabis license in Bristol, where it was only 3 months. So I almost became the first, but I was the first nurse. And yeah, as I say, I'm the Chief Operating Officer currently at Releaf. That's me.
And that was a short summary as of everything that you've done. I mean, that's the crazy thing.
It can be very boring to listen to someone talk about where they've come from and everything. So.
Not at all. And I think that for you to be part of this first webinar, the nursing focused webinar for MCCS, was important to me because of exactly what you've said, of being the first nurse to be setting up a clinic and to making those strides. And for me, certainly from my advocacy background, and then hoping to become part of the medical field, or the medical field in practice in the UK in cannabis medicine, you were on my radar so early on that it's such a pleasure to have you on here and inspire hopefully more nurses to take part in cannabis medicine. But Graham was the first nurse to set up a cannabis clinic in the UK, so amazing leap forward for cannabis alone and for nursing. So Ellie, for you to do a similar run through quickly, because we will talk about all the individual things that you've both done, just to introduce yourself.
Yeah, hi, so thank you for having me as well tonight. My experience in cannabis is more in the background, as I call it. So I got into cannabis about 13 years ago, doing the Sativex research studies and Epidiolex. I'm based up in Manchester, so I was the research nurse leading them at the Christie Hospital. I found it all very fascinating to see its effect on the patients and to deal with it, and obviously come across all the pros and cons with using a new medicine, and also one that everybody knows with the recreational use of it. I did that for a few years. I then went off into the pharmaceutical world, and then got offered a job with a Canadian company doing their medical liaison roles. we did that for a couple of years, and then COVID hit, so went back into the NHS. But along with yourself, Sophie, I just knew there was something there just needed to help support nurses, because so we set up Nurture Nursing, and with Nurture Nursing we do a bit of everything, and you can go into it in more detail. But the reason I brought you along, and I think you should give your introduction as well, is because of all your clinical knowledge and your hands-on experience and your product knowledge. I have got lots of knowledge in CQC, in research, in all the barriers that comes along with trying to do pretty much anything behind the scenes in cannabis. But I quite like those challenges, and nobody really ever knew the answer, so it was, let's try and find the answer to all these questions that I have. And it's been a really interesting journey. I do still work in pharmaceutical company in a role that's not to do with cannabis, so it keeps my feet in the door with understanding all the new rules and regulations that are out there as well, and met some really interesting people along the way.
No, thank you for that. I realised that through that miniature CV that you've given us, that we forget one of the core things that I remember being really so impressed about when I first met you was that you were a research nurse on the cited clinical trials, which was the first, and still is, one of the only licensed cannabis medicines available, if you're lucky, on postcode lottery on the NHS. So that is an incredible feat in itself. So the first licensed cannabis medicine to be available in the UK. Ellie was one of the research nurses working on that clinical trial, which is so cool. As someone who works in clinical research now, just how complicated that process would have been for something as complicated as cannabis is really intriguing, and I want to talk a little bit more about that later on. As you kindly highlighted, I will do a sort of miniature CV for myself. I came into cannabis medicine because my partner had Crohn's disease and found cannabis medicine very helpful, and I was a nurse at the time. I was wanting to do my own reading because I was unsure, and as many of us in the nursing profession are, and I'm particularly thinking of Graham, your previous experience in your role, that actually our training around cannabis was previously about whether or not you directed that individual who disclosed that to you to drug liaison or mental health, and they couldn't go to one without the other. And that was my training and my understanding. So I wanted to help understand whether or not my partner was actually making things worse for himself. But actually, we met a lot of people through that who were other patients who were finding cannabis medicines helpful for them pre-legalization on prescription, and I supported him setting up and a number of other patients setting up a grassroots organisation called United Patients Alliance. I then, post-legalisation, I was asked to speak at the Royal College of Nursing for cannabis medicines in nursing practice, and then through that we set up CPAS. CPAS morphed into exactly that, as you say, Nurture Nursing, which is focused on education and for nurses in cannabis medicine. I was lucky enough to be asked to be a clinical trial manager for a phase 3 feasibility study for cannabis medicines or cannabis flowers, and I worked in the Integro clinics with Dr. Anthony Orderman as their lead clinic nurse up until a few years ago. I now work in clinical trials in gynecology, oncology at Guy's Hospital, as well as doing Nurture Nursing. So that's my mini synopsis. So I'm very happy to have a number of nurses on as audience members tonight. If you have any questions, I would ask you to save them right at the end, and we will address them, as many as we can, with the time that we've been given. So I just wanted to start with, obviously, that you've both sort of given your miniature CVs, but one of the things you both highlighted are that obviously you've moved between the NHS and private back to NHS. And I know that from an interesting interview I watched recently with the nurse from Integro Clinics who's there now, they talked about nursing, NHS, how integral that is to your identity to some degree, and the loss of that, and how difficult people find it, particularly nurses, moving out of NHS into private, and what made you make that decision, because it's where we all start. So I'd be interested to hear what the reason was for that, behind your feelings. Graham.
Yeah, gosh, that's a really good question. It's really a really long question, really, but I'll try to keep a short answer. I have to say, I had great peers in the NHS. I mean, I owe my success to the people that I worked with. I don't feel like I'm anything special. I feel like I just had a lot of good people around me. But I also felt that I was dying in the NHS, and I wasn't going to progress forward. And so when Lifeline, which was a heroin charity, approached me to be their dual diagnosis lead, I just thought, yeah, I've had enough. I want to go. But the thing that struck me the most about leaving the NHS, when you go into the private sector, or when you go into charities, is this perception that clinical governance and safety is out of the window, and you're mavericks and you do everything. And I think that drove me to be the opposite. It drove me to be, right, I'm going to make sure every policy, procedure, yada, yada, is all in place. We are not going to be perceived as the NHS is the safe place to be and private or charities are unsafe because they don't have the governance. So I work very hard to make sure that we have all of our governance in place. And when we had our interview at Labour Clinic, I pushed and pushed and pushed, and the panel that I now work with, because I now represent the CQC as well, I'm a specialist advisor for the CQC. I pushed them and pushed them, and I felt like, you're not leaving your seat until my presentation's done. And I got 3 outstandings for our review, but then when they do the ratification, as it were, they have to go to a panel, and the panel wouldn't give me the 3 outstandings. And I fought and fought and fought, and in the end, I got the 1. I got outstanding for well led.
I mean, that would be clear from you pushing, I think, surely.
Yeah,
they would not have a reason to not give you that.
Well, they worked really hard. I think the reason that they asked me to become an advisor with the CQC was because I pushed so hard, not because I did anything special. I just was determined to show them and general public, really, that coming to a private organization or any organization is just as good, if not better, or safer than being in the NHS. So I don't think in reality now I could go back to the NHS at all. I go to the NHS for my own private, just to disclose, it's no big deal. I have kidney stones, and I've always had kidney stones, so I go regularly back to the NHS. And when I go, the service I get from the receptionists is really it's really quite not great. And I want it to be great, because you feel very loyal to where you've come from. It's like, I come from Birmingham, so I'm very loyal to Birmingham, and I'm very loyal to the NHS because it's where I learnt my trade. And I want it to be good. But unfortunately, the treatment I get, or not so much the treatment I get, but the waiting around, or the standing at the reception on your own, thinking that the 2 receptionists that have got your file are going to help you, but they just continue to ignore you, gets frustrating. So I couldn't go back, and I really enjoy what I do now. That's the main thing. I think I really enjoy what I do. I find in working, my background in psychiatry, working in antipsychotics, and then in drug addiction, I always feel a little bit conscious about whether I'm sounded like a salesman, but I've never experienced a medication or a molecule that's improved patients' lives as much as medical cannabis does. In psychiatry, you have your antipsychotics and people feel well, so then they stop taking them, and then they end up getting sectioned and going back. And in addiction, people stay abstinent for a while, and then potentially, they fall off and they go back to their substance misuse. But as I said, cannabis, I think, is really impressive when you get young people who have been socially isolated suddenly having driving lessons, or people that haven't done any gardening for 10 years suddenly are doing gardening, but they don't even realize that they're doing gardening. They say, "Oh, I've started a bit of gardening." I go, "Well, when was your last garden?" And they're like, "Oh, 10 years ago." So I do truly believe in what we're trying to do with medical cannabis. Whether the government or whether the NHS will adopt it, I don't know. And I don't spend too much energy or time on that. I spend more energy and time on trying to, treat the patients that we have coming to us the best way we can.
And I think that's really interesting that you've highlighted that difference, and that I know I certainly felt moving for the first time from NHS into private, that there was a real fear of entering this space where I didn't feel as safety netted, and it was very much up to myself autonomously to make that conscious decision, as you say, that I'm going to be more policy led than possibly I'd ever been previously,
Yeah.
because you are more autonomous and independent. And that's a really interesting shift, that encourages a particular kind of nurse, I think, that is happier to work in that autonomous way. And it's an opportunity. What I've found is a lot of the nurses that I've met that have made that move into cannabis medicine specifically, I think, is that you're all nurses who have a very particular voice and opinion, and that you have just really found your niche to be able to have an opportunity to lead in the way that you would have hoped to lead in an NHS setting. And I think that that's really one of the things that we talk about with nurses who approach Nurture, for example, who want to work in cannabis, and they sort of ask the questions that I'm going to ask you guys, which is like similar, as you say, what's the difference between working NHS and private other than money and sleep? Like, that is a key factor. But I think the other thing that I found that I was pleasantly surprised by working at the clinic is that I had more time. To give to patients and to have those conversations and build up those long-term relationships. And that was a real pleasure and a real surprise that I could do that with them. And exactly as you say, you would look after someone for maybe a year, and that you would be able to say, oh, you're going back to school, or you're doing your GCSEs with someone with ADHD, severe ADHD, and you're saying, oh, okay, like, I just want to remind you, when you feel like you're not moving forward, that when we spoke 6 months ago, like, you didn't even want to go outside, or you couldn't focus, and you had like anxiety about a lot of things. And that is a real pleasure. And I'd say that to nurses a lot, which is that you do get that time. And that's, for me, was one of the key differences. I know, Ellie, you said you've moved as well. You've moved back and forth quite a lot between the NHS and private. Sort of, what are your takes on what you found the differences to be, and where the pros and cons are?
I think it's, very similar to what you guys say, but I love the NHS, but I think I have almost like a 2-3 year limit until as you say, I don't feel I can give the care to the patients that I want to give. But I've always done roles that are quite autonomous. Anybody that's been in clinical research, it is, a very autonomous role, and you are out on your own. And the reason I moved first time was because I'd got to a band 8 level, and the further you get up the banding, the more you get put into an office and given a load of paperwork. And I was like, I don't want to be doing this. So to me, it was an opportunity to go and try something new. And you do feel like you're kind of betraying somebody almost by leaving and going, as they call it, to the dark side. But I've been told that many times. But I think as nurses, and I find it in both my pharmaceutical jobs and all other jobs I've done, is especially in the United Kingdom, nurses have a lot more autonomy and power and skills compared to a lot of other countries. And people are always astounded by what we can do as a nurse in the United Kingdom. And I'm constantly having to explain to people, like on sales targets, that they shouldn't just have doctors, they need to have nurses and pharmacists as well, who are extremely important and do a lot in all areas of healthcare, private and NHS. It's, I think it's both for my kind of self-worth and getting what I want out of a job. And I'm not going to lie, it also with I've got a young family, and you get a lot more flexibility a lot of the time as well to work in the evenings and work in the I'm one of those annoying people that gets up very, very early and like to get a lot done then. And I get a lot of self-worth, and I like the fact that I'm in control of what I'm doing, rather than having to do things how I'm told, but not agreeing with it and not thinking it's good or safe for the patients. But I do miss my patients that I had in the NHS. So my last role was a community practice nurse, and I do miss a lot of it, but there was, you've got to weigh up the pros and the cons of what suits you and also where you want your career to go. And I think in the NHS, I'm not going to get that career progression that I would want and can get in the private sector.
I think that's very fair, and I think that's probably echoes a lot of what Graham and myself have said, which is that it's an opportunity for you to, as a nurse, have a bit more control, I think, over how you work. And I think that's a really wonderful thing if that's something that inspires you or energizes you. So I suppose it sort of leads nicely into the next question. Yes, move between the NHS and private, and those are all the things we've talked about are quite generalist between NHS and private, regardless of area. But why cannabis medicine specifically? Ellie, seeing as your mic's off.
So why cannabis? I think I'd spent a few years doing a lot of phase 1 studies in palliative and pain, which is where I had the Sativex studies. I like, as Graham said, you can't, I've not experienced a molecule that has such an effect, but also, especially in the pain and palliative world, I spent a lot of my time trying to manage side effects in the polypharmacy issue. And I think the thing I loved about cannabis was the lack, that the side effects were very, very minimal compared to a lot of all the other drugs that I was using either in trials or out in the clinical aspect of it. It's obviously something that I knew of. It's always a joke amongst my friends because I'm married to somebody in the police. So it's always getting his negative side on it. But it's, even though they've now all been trained up in Greater Manchester on medical cannabis and understanding when it's, needed for medical reasons, which I thought was very interesting. But I just find it a fascinating drug. The people, I always say to people, it's people and product is what makes your job worthwhile. And I've met so many fascinating people along the way. I've been very fortunate. I've been over to Canada quite a few times and taken people, gone and met lots of people over there. We've got our little nurse network over in the USA, haven't we, Soph? And, we don't do much work together, but we have good chats and we just, have good debates about everything. And I think it's part of being a nurse is we find people very interesting and like to meet new people. And it's, the product and people are my two things that I think give you a lot of self-worth and job satisfaction.
I really like that. That's we are recording this, so that is a lovely soundbite. We're just trained that way now. But it's really good, and you're so right. It's really interesting that it is people. And I remember when I trained that it was. I think I remember a lecturer specifically saying on my very first day of lecturing everybody in that room was basically saying, now you're all here because you're really, really nosy people and you want to find out as much as possible about other human beings. I was like, oh, that seems like a good assessment of an entire room. But so I would probably ask the same question of Graham, because you touched a little bit earlier about what you find fascinating about cannabis, but what brought you to cannabis medicine specifically, because you were spearheading it quite early on?
It's really funny because I worked in drug and alcohol services for 14 years. So I covered Oxford, London, Hackney, Tower Hamlets. So I was the director for drug and alcohol services for really kind of run-down areas of the country. So cannabis was, if you looked, when we used to do assessments, it was heroin, crack, spice, benzos, alcohol. Cannabis was like the right down at the bottom of the list. So we never really took cannabis seriously as an addiction service, because the treatment that we had for cannabis was 12 steps or group work. There was no methadone or buprenorphine was for our heroin addicts. benzos or diazepine. We would do reductions and alcohol. Obviously, there's other complications with ascites and stuff. But cannabis wasn't something that I, in my mind, classed as a difficult or scary or as a hard to treat drug. And I wasn't, to be honest with you, so convinced about its efficacy. So I went out when I started work for Althea, when I first started in 2018-19. I went out to Ontario and I met a wonderful doctor that maybe some people on here know, called Chris Blue, Dr. Chris Blue. And I spent time with him in his clinic in Windsor. And I honestly thought, I was there for about 3 weeks and I went back afterwards. I thought he'd brought a load of actors and actresses into his clinic because he was prescribing cannabis for the general population, you know, all ages. Some people were on Zimmer frames or in wheelchairs, and they were coming back and without a Zimmer frame or with a walking stick, less than a Zimmer frame, or coming back and saying, "Doctor, you've healed me. Doctor, you've healed me." I even went to a local casino that we were staying in, a hotel, and I did my usual, I'm only going to spend 10 Canadian dollars. After that, I'm leaving because I'm not a big gambler. And I went to the roulette wheel, and this man said to me, "You're English. Why are you here?" And I said, "I've come to learn about cannabis." And he said, "Oh, I've got a doctor, Dr. Blue." And everyone in this casino as well was treated by Chris Blue. And I was astounded by every patient that come in the door, whether they came in on their own or come in with their partner, how well they were doing. I honestly thought that I was being set up. There's no way that all of these people can come into a clinic and almost saying, "I'm healed." And the more and more I worked with Chris and the more and more I understood it, I thought, wow. And then obviously when I started working at set up my access clinic, our first patient that we had, unfortunately, he had a stage 4 brain tumors. But towards the end of his life, the first prescription.
Sorry, Graham. I'm so sorry. Your microphone just sounds like it's gone really far away.
Oh, sorry.
No.
Can you hear? Is that okay?
No, that's better. Thank you so much. Okay. Sorry, I'm so sorry. I interrupted your flow.
No, it's fine. So the first patient that we treated, who was terminal at the time, we extended his life and the quality of life. And when we initially started doing, I'm still skeptical, I'm still happy to set up services, but when we started doing all the EQ5D5Ls and all of the questionnaires that we did, and you looked at the results of people ongoing, you know, the improvements of BPI or GAD7, whatever tools they used, it was, and that was when I really became hooked into thinking, well, actually, this is really, really interesting, and we're really making a difference, and I really enjoy it. So I know I apologize, that's a very long story, but I wasn't so convinced because I'd worked in heroin, which is seen as a much harder drug than cannabis. I was very skeptical at the beginning, we should say.
No, and I can certainly see exactly as you say, like that's my familiarity with it, is that we list, like when we talk about substance abuse, that there's like a hierarchy of drugs or a list of drugs, and cannabis is often at the bottom almost as an afterthought. But it's still, when I first started, when I was working in A&E, that we were still being asked if a patient was disclosing that, we would say, oh, they go to drug liaison or mental health. Mental health wouldn't take them if drug liaison, if they were still taking cannabis, and vice versa, and they would ping back and forth between them. I think the interesting thing about what you've said there is that I think when we talk about, from my experience anyway, that working at A&E, ITU, that all felt like similar to what you said before, which is that feeling that you put a lot of energy, or you and your whole team put a lot of energy into taking care of someone, almost patching them up to the point where they just go back into the environment that brought them into hospital or into care in the first place. And it's sort of a never-ending cycle. And there's a lot of pleasure in that one-to-one experience and interaction, and that you've given someone that moment of relief or hope in that moment. And that was always very valuable to me. But I think that moving into cannabis medicine specifically and research, I suppose from my perspective, I moved into it from a personal perspective because of my partner's experience with it. But for me, it feels like a hopeful area of medicine. I think that's a really key thing for a lot of nurses who feel burnout, like where they're working at the moment. And what I do say is that cannabis medicine feels very hopeful. It feels like it's at the start of its journey in terms of a field of study and a field of practice, and that there's a long way to go. And I think that when we talk about, from my experience or my understanding, the end of every interview, article, like news story is always, the end of it is always that we need more evidence, more clinical trials. So both of you, so I'm going to ask Ellie you in a minute, because I think both of you have used the word molecule, individual molecule. And I think that the thing that we've all understand is that cannabis is a complicated group of medications that in any combination could work. And in my dream world, I would break it all down into individual like cannabinoids and then put them back together, having known what they all do individually. Now, I've been told that will take decades and millions of pounds, which is true. But it's interesting that you both used the word molecule. So I think, Ellie, in terms of like clinical trial evidence to produce the evidence that we, both I and Graham have talked about having some kind of apprehension. I was worried that my partner was actually doing more harm than good. Obviously, Graham's talks about not feeling like you were totally convinced of efficacy at the beginning. So clinical trials is how we do that. But what might be some of the challenges to actually conducting thorough clinical trials on cannabis medicines?
Money would be my first answer to that. The amount of conversations I have had with people about setting up studies, and a lot of companies are very new and haven't got the financial investment behind them, and a lot of people I find are setting up some companies and things who aren't medical, so they don't have that knowledge of how long and how much a research study costs. When I have tried to set one up, one big one that I tried to set up, and I've never had so many conversations with the MHRA to try and get through all the hurdles, because they didn't know the answer to anything. And they were like, we've never been asked this. And so there's kind of the two aspects. There's the people, the company or the owners of the product who want to do the study. They need to be able to produce the documentation, the lots of different forms, which I won't go into the details of, that they just don't have the capacity or the finances or the ability to be able to do it. Lots of people can, but a lot of people I've spoken to can't and don't understand it. And then there's also the MHRA aspect and getting a study registered and through the right ethical process. The United Kingdom is renowned for being one of the most difficult places in the world to get a study approved and undertaken, and one of the longest. However, that also has the benefit that if you get it through the system, then the results of what you get are I can't think of the word, that their results that are very well kind of received, and people take them very seriously because it's results from a study in the United Kingdom. It's got a lot better. So the first time I tried to get things going, and the furthest I'd got with the company was about 6 years ago, and we did get quite far, and we got lots of the documentation. We got through a lot of barriers from the MHRA, but it was money that stopped it at the end of the day. When we put in all the finances and to be able to get the results that would have a significant benefit and a purpose of what you were doing, because what NICE needs is a good RCT trial, and they are very expensive. But it's kind of one of those catch-22s that without it, I just think we are going to carry on quite slowly progressing. But that's just my experience.
And I'm not surprised that you said money, because I think that is like the core thing, and that most people don't quite understand how much money it takes to run a clinical trial and set up the infrastructure for a clinical trial and set up all those systems and deliver it. So I think a lot of people, when we talk about for nurses, for evidence-based practice, I think a lot of the communication that I have with nurses is about cannabis medicines, and having those day-to-day conversations with their patients is often patient safety, so making sure that your patient is disclosing cannabis medicine, or cannabis use to you, either by a prescription or not, and that our responsibility or duty of care is to sort of guide them towards either a legal access point where they can be assessed by a doctor, or that we're looking at evidence-based practice. So these are things that underpin nursing, are the patient safety, evidence-based practice. And this is where we're sort of being challenged, is that a lot of our evidence is not a UK-run clinical trial. That doesn't mean the clinical trials haven't been run in other countries. Israel produces a huge amount of research, for example. So that, I think that's the next question, I suppose, is that because the UK is relatively unique in our experience, that patients come across interacting with this private system where we have to, patients being asked to pay for medications and clinical care, where in this country we are not used to that. They're having that international influence in the discussions with international clinicians, like, you know, you've talked about our connections with the Medical Cannabis Nurses Association, and Graham, you talked about Chris Bloom and visiting these other countries. So how much value do you think there is for nurses who are interested in learning more about cannabis medicines in understanding or talking to or reading information from international clinicians? Graham.
Before I answer that, I want to just go back to something you said, Sophie. When I as a psychiatric nurse, I worked in UCH, A&E, crisis teams, community mental health teams, etc., etc. And it was, I think, one of the most frustrating times in my life in the NHS was dealing with patients who were being pushed from either substance misuse services or community mental health services. And the community mental health service would say, we can't treat them because their psychosis is relating to the drugs that they're taking, or the CMHT, the drug service would say, no, they've got mental health problems, that's why they're taking drugs. And unfortunately, the only person that's in the middle of this is the patient all the time. And that's why I thought that the publication that CMC, well, it was a survey, wasn't it, came out with about the amount of, 1.6, 1.8 million people self-medicating. And I think when I believe there is a lot more people out there, whether it's cannabis or whether it's other drugs, are self-medicating. But unfortunately, the current system, psychiatric system and substance misuse system in England anyway, just doesn't know how to deal with these patients. So they push them one way or another. And if they're in hospital and they become stable, then they're substance misuse. But if they don't become stable, then they're potentially got mental health issues. Anyway, going back onto your question, I think all of the research that I look at is predominantly from other countries, whether it be Israel or whether it be Canada. I've got a blog, and I think I used to post it in I haven't done it for ages, I used to post it in our nursing group, where you get questions and answers, but all of the research that I get comes from other countries. And I wonder, and I mean, I don't have an opinion on this, and I wonder whether the UK, whether we're already missed the boat to be able to do clinical trials now, because we've been going now for what, 5 years, has it been? Something like that. And we've got loads and loads of evidence. We've got lots and lots of patients. We're in the system now, 40,000 patients. And a lot of them we can produce evidence based on a validated screening tool that they're doing well. But to go back to, as Eleanor said, to a clinical trial, which is, most pharmaceutical companies spend at least 5 years doing a clinical trial, don't they? And then that costs millions and millions. And is there the appetite and is there the money within cannabis for people to actually say, we run? And I know there are a couple of clinical trials going on up in Scotland with the Nanda guys, so fair play to them, and I hope they do well. But I'm wondering whether we're just going to keep plodding on this road, and the numbers are going to slowly increase. But we're never going to get I hope we're going to get the saturation that we want. But are we? We're going to keep trying. We're going to keep trying, but and again, I don't know whether my sense is that we've missed the boat in England to do a full clinical trial based on getting your IRAS ethics, approval and everything that you have to do it. I'm not sure that the people that generally invest in setting up cannabis clinics want to invest that much money in a study as well as setting up the clinic.
No, and it's an interesting point, because I think the conversation around observational studies and clinical trials, and that conversation going back and forth between NICE and the NHS as well, I think that there are particular groups like the pediatric epilepsy, like rare forms of epilepsy, where arguably they are such a small population of a patient demographic that it would be difficult to run, or it would be difficult to fund or find funding for a clinical trial for such a small group of patients, sadly, because of that being a driving factor in pharmaceutical companies paying for a clinical trial, so they will get drug sold to the NHS at the end. If it's a small patient group, there'd be less inclination, right? So for some groups, I think there certainly is a good, strong argument for potentially like a clinical trial not being the best option as an evidence, like production of evidence for that group of patients. I think for patients like chronic pain, where say it's like 10,000 people, or one in 10 people have like a form of chronic pain, and in this country, and I think that
12 million apparently.
12 million. So yeah, that's a sizable patient group that would be good for clinical trials. So I think that your point is true, and I think that there's like value for both. The conversation with NICE is whether or not they are going to accept observational evidence for smaller patient groups, and I think that is definitely a conversation worth having with them, and that we need to keep pushing for that, which I know the MCCS and things like Hannah Deacon are certainly. I wanted to
sorry, if I just might add, the NICE guidance currently for pain, I'm sure you're aware of this, is that patients are not supposed to be treated with CBD. It says CBD unless they're part of a registry or a study, and that's the current NICE guidance. It doesn't even mention THC or cannabis as a whole. It says specifically CBD. So I mean, it's trying hard for us to not be successful, but we'll try to turn that around.
But I think I want to just highlight the fact that you are like one of the keys of moving a field forward is paying attention to things like that. Like, you have to be smart enough to find, I'm struggling to find a word other than loophole. You have to be creative. You have to be creative about how you safely, legally, and like move this forward, because exactly as you say, I think we all entered cannabis medicine and found that actually this needed the nursing workforce, the clinical workforce, to be more tight on regulation, policy, patient safety, and like protecting our PINs, protecting our patients, all of those things, than previously we may have had to be in the NHS. So I think that is really important that you've highlighted, is to pay attention if it's something that you're interested in. And I think that when nurses come to us and say, I want to work in cannabis medicines, I want to give a sort of quick overview of possible roles that exist in cannabis medicine. And I think between us, we've done all of them so far. So I think there's the obvious one, which is being a clinic nurse. So having that patient experience and face-to-face, or as close to face-to-face as we can get with virtual clinics. And so there's that joy that I talked about, that really is, that you've talked about, Graham, as well, moving patients' health forward in a really, really positive and sort of a way that's very long lasting. And for me, that was a lot of getting symptoms under control for patients who had previously, because of the lack of people being able to, their clinicians actually listening to their disclosure and actually taking it seriously in the NHS, that actually they have withdrawn from the medical system altogether, people who have very serious mental health and chronic conditions. And that through nursing staff being the first point of contact in a clinic, and actually being the people who they spend most of their time with, that you actually rebuild trust in a medical system, and that we're a group of people who will listen to you and take care of you, and that actually through cannabis medicines you can encourage people to re-engage with like longer term therapies like physiotherapy or talking therapy or other programs that actually this is a possible way of getting symptoms under control enough to engage in other things. And then the other thing that we talk about is obviously research. So actually delivering research as a nurse and actually doing that, which is a very different way of thinking. I think Ellie highlighted this, I think, before, which is that there's a difference in thinking between research and clinical practice. In clinical practice, you are encouraged to tailor care to the patient. In research, you are trained to fit a patient to a protocol. You have to look at the patient's whole picture and see if they actually are eligible for the research. And that's a very different way of thinking and attracts very different kinds of people. And then the other bits are, the other roles available are things that I really advocate for, and for you guys are prime examples, are leadership roles, nurses being in higher points of leadership within a business, within clinics, in cannabis medicines, that give you that opportunity to build it in the way that you think it should be run. And I think if I could ask both of you to sort of highlight some of the challenges that particular aspect or those particular roles in cannabis medicines that you have come across and how you've overcome them, I think a lot of nurses would be very interested in that. So in terms of, I'm going to start with Ellie, so I think you've had your mic off for a little bit. In terms of like running your own consultancy, being higher up in like pharmaceutical companies and sales reps and all those things, what are some of the challenges you came across as a nurse, and sort of how have you overcome those?
I think I've had, not badly, but a lot of the times people are like, you're just a nurse and you're not a doctor.
So we're just...
It's okay. I think it's the whole, this is more from other countries who don't appreciate the value and what a nurse can do within the UK and what knowledge and what experience you can have. It's once you overcome that, then it's also just, and again, it's with this study that I was talking about, is people just couldn't believe what I was telling them, to the point where I had to set them up a call with the MHRA, so the MHRA could tell them directly exactly what I had just told them about everything that was needed, etc., to be able to do what they were wanting to do. And I think it's having confidence in what you're doing, but also going back to the whole people aspect, is having a good network around you to bounce ideas off, because it is a small community, and we do all have at one point over the years met or talked or worked with each other. And it's having, I will never in anything I do have this competitor thing, oh, you work for such and such, I can't talk to you. I think it's always having an open door and an open phone line, just to be able to run ideas past each other. And I still speak to people from 6, 7, 8 years ago. I still see the doctor that I worked with on the Sativex studies and get the odd text off him. And it's just having that really good network around you to have confidence in what you're doing, because it's new. A lot of people quite often don't know the answers, especially in the research side. And it's owning what you're doing, and as I say, but also admitting when you don't know the answer as well, and then overcoming the hurdles and getting that answer sorted and written down, and then it's ready for the next person.
Yeah, absolutely. I mean, that's really valuable, I think, and we're very lucky, just the three of us, to be able to like sit and talk to each other, and hopefully now it's being recorded, that this sort of will be able to be accessible with more people through that network. But I think that what you've said is really true, that actually I remember very, very clearly from my nurse training, that I remember someone very clearly saying, when you reach the point where you think you know everything, that is the point at which you probably are practicing poorly. And I've carried that through my entire career, which is that to enter a space where you feel like you don't know it very well, or you don't feel confident, that actually that just shows that you're being brave enough to move into a new place where you are learning, that you're constantly learning, that you feel that you don't necessarily know it all, is because you're learning still. And that's a really wonderful journey in a career that nursing gives you in general, but cannabis medicine is, right, like I said before, right at the beginning of that journey. So I think that's a really valuable point. Graham, I know that you've had lots of different leadership roles, either within companies or from companies you've started. So sort of hurdles or challenges of doing those leadership roles and leading other people, and hurdles and how you've overcome them.
And I think the biggest challenge that we have, and that's everybody that's here and in the cannabis space right now, is everything is guidelines, aren't they? Everything is guidelines. There's no law, there's no legislation, it's all guidelines. And I think if I've had any frustrations, it's within organizations where everybody's had a different interpretation of what a guideline is, and what to license medications, or is that therapies, is that this or whatever it is. So I feel very supported where I am right now, and I feel that we've got a very open dialogue about the guidelines, and obviously what's there, 35 clinics now, and I'm sure every clinic will be reading those guidelines and trying to work out how they can make patient access easier for a patient if they can look at the guidelines. And when I've done inspections with the CQC, a lot of the other clinics as well are following guidelines, but they're following the guidelines differently to what I am currently. And that's not to say they're wrong, that's just their interpretation of it. So if I had any frustrations, and it's not with, I have to say, it's not within my organization or anything, it's within the fact that the patients that we're serving are having to pay 300 or something pounds or more or less or thereabouts a month for treatment that actually is working for them, and the treatment that they've been accessing before, you know, whether they've had every medication in the BNF and hasn't worked, and suddenly they're using cannabis and it's working for them, and then we have to charge them. So my only frustration is I'd love to get to a point where we can offer treatment, you know, as long as it stays privately, it's still going to need to be funded. But I'd like to get to a stage where we can offer really fair, you know, nothing more than a gym membership a month for patients to be accessing treatment. But I don't have. I've learned so much within, you know, not just with the people on this group and the cannabis nurses and the doctors. I've learned so much in this space, and I think the cannabis space is quite a unique space because we all know each other, don't we? We all know the clinics, and I don't call the other clinics competitors at all, ever. And I know we use that language that so and so is a competitor and this competitor's doing this and yada yada yada. I don't ever think about another clinic being a competitor. I just think other clinics are doing things slightly different. They've got a different website. They maybe have got different doctors. You know, I don't see them as competitors. I'm striving to make sure that we offer the best service we can. Whatever clinic A does down the road is irrelevant to me because I want to do what I want to do, you know. So I should have some frustrations, and I have done in the past, but I don't have any right now apart from the cost of medication and treatment for patients.
Yeah, and I think you're right. I think that sort of that is an overarching goal of the whole field, is that from the clinician perspective anyway, I think is that we would like it to be as accessible as possible because we see such positive results clinically. And I think what you said about, I think you just highlighted something to me and my brain's just like flown out of my mind. But I think that leadership, like when you say you haven't got any frustrations, I feel that's because you have like moved those frustrations out of the way. You've moved them forward. So I think that when you talk about having this goal, I think that is also a really valuable takeaway, which is that in this space where we've already talked about as a nurse, you can have more autonomy and more potential for leadership. And if you don't feel like you're progressing in the NHS, there's an avenue here for you to be able to build something yourself. And I think that having a goal in mind actually will just keep you, like we said, continuously learning, but will keep pushing you forward and maintain your passion. Because I think particularly for nursing outside of cannabis medicines, I think that we are very vulnerable as a profession to feeling like we are burnt out and that we are like that haven't got that same passion. People talk about it all the time. You know, burnout is just losing the passion for the thing that you know you love, and that's the frustration that people have where they are now. So I think that this, again, for me, as I said before, it's very hopeful. So having those goals to move towards. I think we are coming up for time. I'm just like, for me, it's flown by anyway. But like that is, if there's anyone who has any questions, I'm going to give 5 minutes for for anyone to put any questions to any of our panelists in the Q&A box at the bottom. But while we wait for those things, I wanted to just ask both of you to think of a takeaway for nurses in the audience that you would like them to remember from what we've talked about today. So something that you would think is valuable for them to know from your experiences and to take away from today. So Ellie, I'm going to start with you. If there's a takeaway for everyone, what would you like it to be?
Network is what I would say to people, is start putting, you know, I'm very much a people person, and I think just get the knowledge and the network around you and get an understanding of what is out there and how things work at the moment, and ask questions, attend events where you can, though I know it's hard to do with the cost and the time, but you know, pick up the phone to people, email people. People are very approachable, and we're always very happy to chat and answer and support where we can.
I think that's a good one, and it's certainly a skill that it takes, and it's a new skill that people need to learn, networking, and that actually to understand that building real relationships that last takes time, and to feel like actually investing that time will be worth it in the end. I think that idea of it being a sprint to the finish line to get to where you want to go, that's not how you move a whole field forward or move your own career or practice forward. So I think that's a really good one. Graham, what would your takeaway be?
I think, I mean, going back to Eleanor's previous point, I've never felt like I'm just a nurse. I've never really felt like that, because I've always worked with, you know, we've worked with F1s, F2s, staff grades, all the doctors going through till they get to consultants, and we've supported them when they've made prescription errors and said, could you just change this prescription slightly because it's not right, you know. So I've never felt that anybody, I don't feel like I'm superior, but I don't feel like anyone's superior to me either. I think it's culture. So if I was going to talk about a nurse joining an organization, I would really look at the culture of that organization, because I think within Releaf, where I am now, we have a really, really open culture where there is no real hierarchy, where there's new doctors that have joined us who've got no cannabis experience, and there's doctors who've got lots of cannabis experience, and I've got lots of experience, but it's about sharing that. So I would say, if you're interested in cannabis, I would look for an organization, but I would look for the organization, and I'd do some due diligence to find out who's in the organization and what the culture of the organization is, and what am I going to learn there. I'm learning loads now about kind of SEO and all tech stuff that I don't really know anything about, but I'm happy to learn and, you know, absorb it. But I really think, yeah, I think cannabis as a molecule in an industry is, just to see the patient's improvement is really, really, you know, phenomenal. But I would say culture. I think the culture of an organization and what everyone's striving really shines through. It really does, and it's really important, because I don't get up on a Monday and think, oh my God, it's Monday at all. I don't ever want to feel like that, you know. So yeah. Culture.
No, I think that's a fantastic one, which is that idea of feeling like where you work mirrors what you value. And I think that is a lot of why people move into cannabis, is because they don't experience it anymore. So I think that it's a really valuable one, and I really love it. We do have some questions, so I'm just going to sort of go through. So I think that we've got one that says, you know, as a paramedic in primary care, are there any other paramedics working in this area that would be interested in networking? So they've spoken to Ellie already, so they've already networked, so that's a really good lesson already. So I think addressing, because this is not the first time that paramedics as an allied healthcare professional have actually been asking to be involved in cannabis medicine. So I'm going to ask everybody, but from my understanding, paramedics still do face-to-face in terms of managing patients. So I think you can be involved. I think there is a difference in terms of training and experience, that you may need a little more support at the beginning because of that sort of long-term management of a patient. Paramedics don't necessarily get the opportunity to do. So it might be good if you were engaged in that role, or you wanted to be in that role, that you would be twinned with a nurse for a little while to give you that support. But it's certainly, I've seen more and more paramedics wanting to be involved. So there's definitely room for networking. We can put you in touch with other paramedics who are interested. But Graham and Ellie, thoughts on paramedics' involvement in cannabis medicine?
It's interesting. We've just had, I wonder if it's the same paramedic, but we've just had
the same.
It might be. We've had a paramedic approach us. I think we advertise for posts all the time, patient support or whatever. So whether you're a paramedic or whether you've got no experience of substances or cannabis or whatever, but you're really interested in the field, I wouldn't say no to anyone. Like I say, if somebody is really driven to work in this field and they apply through the usual, Indeed or Otter or LinkedIn or wherever they apply for a job, just go for it. I don't think whether you're a band 4 nurse or a paramedic or whatever you are should change your drive or your motivation to want to work in this field at all.
I think, and having spoken with Nathan, I think one of the problems that he's having and also I'm having is everything's in London and we're all based up north.
Yeah, I think that's probably true. So I think that actually having that, like you say, you've taken on that networking. There's someone else who's taken on your networking advice as well. So we've got someone who says that I'm an IP and a clinical lead in an AD in charity. I agree cannabis still appears quite low on the hierarchy of drugs list. However, I want to get involved with medicinal cannabis community. What organizations, meetings, where would you suggest that I start regarding networking as a clinical lead? So they already have experience clearly as in sort of leadership roles. So what are good opportunity, what are good events, places to go to meet other people and network?
Is that for me? Well, I try to attend as much as I can the different conferences that go on. You've got the MCCS conferences that go on, the webinars, the MCA, the CIC, any of them that happen. I try to attend the drug science ones, the patient ones for drug science, and to network at those. Really, I don't attend to manage to attend as many as I used to, but I also find that when I do attend, quite often I bump into the same people, so it's good to catch up. Actually, the one conference that I did really enjoy, and it's not a plug because I don't have any shares in them or whatever, it was Cannabis Europa. I actually enjoyed Cannabis Europa because it's a big one. It has lots of the clinics and licensed producers and lots of talks. So I think that one is, but I believe it's quite expensive. I'm not sure how much it costs, but I felt like I get a lot out of that one, particularly because I meet new people as well.
Yeah, and I think Cannabis Europe is a good one, sort of overall industry. If you're just starting to enter it and are not really sure which direction or which role that you sort of are looking at, Cannabis Europe is a good one because there's so many people and so many organisations and businesses. I think another one that if you are interested in sort of a very much more sort of research clinical trials aspect, CT Can in May, which MCCS membership does, I think, give you a code at the moment if you want to buy tickets. That will mean there is a discount on those ticket prices, but it is in London. And it is international researchers from all over the world presenting their clinical trial evidence on cannabis medicine. I went to that last year and I really thought it was fabulous. So that is also a good one if you're interested in that. I'm going to do a last one and then we are going to say goodbye because I think we're 5 minutes over, but I just want, because this one specifically was around mental health. There's a lady saying, Kelly says, I'm an RMN in Scotland specialising in mental health and substance abuse privately. As a clinic, we are finding it hard to get regulated from Health Improvement Scotland to prescribe medicinal cannabis. They have declined us working under shared care agreements with the CQC. Any advice on how we can sort of start to overcome that? It's a big one.
I didn't get all of that, but I think
so. My understanding is that they are struggling. They're a mental health and substance abuse clinic, and that they want to be able to prescribe cannabis as part of their regime, but they're struggling to actually get approval to do that.
Well, if it's an NHS clinic, I mean, that's the same as the UK, isn't it? It wouldn't be available through the NHS apart from the usual ones that are licensed. So it would still be I believe that there's some England clinics are in Scotland already as private clinics, but to be able to get, Yeah. But to be able to get access to, they don't have the CQC there. They have a different organisation in Scotland. It's H something or other. I can't remember exactly.
Okay.
But I thought there was already a clinic there. So isn't that already set a
They've got a
precedent?
clinic there, haven't they? Is it Sapphire?
Yeah, I thought Sapphire had a clinic there.
They do. So I don't know if this person is specifically talking about, I don't think she's talking about a specific cannabis clinic or a cannabis prescribing clinic. It's a normal substance abuse management clinic that they would hope to prescribe medicinal cannabis in. But Kelly, I think if you have any more in-depth questions, sort of you can give more information. I think we're all very happy to answer, give our best, or try our best to answer them. If you want to just email the MCCS sort of general email address, then we can direct those questions with a bit more information to people like Graham, who will have good experience for this. So unfortunately, I don't have any other time for questions. If we have any more questions we haven't answered, we can always try and answer them as part of an email. But it's been a real pleasure to have both of you on and to take part in this very first MCCS Nursing Focus webinar, and I'm really happy that you both agreed to do it. So thank you for both of your time. I know it's very valuable, and thank you to everyone who has stayed with us for the whole hour and these additional 9 minutes as well. So thank you very much. So have lovely evenings, and this will be available. This is being recorded, so this will be available for you to watch again or to share with whoever you feel like might benefit. So thank you very much, guys.
Thank you for inviting me. Thank you very much.
Thank you. Take care, everyone.
Bye.